All right, continuing with environmental emergencies, and we're moving on to frostbite here. So, frostbite is the opposite. And we see this, of course, in the winter months and when people aren't wearing the appropriate clothing or they're constantly exposed to cold issues. So, trauma from exposure to freezing temperatures and freezing of the intracellular fluid and fluids in the intracellular spaces. So it starts damaging the cells. Most frequently affects the feet, hands, nose, and ears, so our extremities. Frostbite results in cellular and vascular damage. Frostbite can result in venous stasis and thrombosis because there's no circulation, right? And then we've got these clot formations. Frostbite ranges from first degree redness and erythema to fourth degree full depth tissue destruction. So that's when you have the black toes. Now, assessment, diagnostic findings, and management of frostbite. Frozen extremities may be hard, cold, and insensitive to touch. So you're doing your sensation assessment and you notice they may appear white, molted, blue, or bluish white, that cyanotic color, but they're not going to have any sensation. History should include their environmental temperature, of the outside temperature, duration of the exposures, the clothing worn, humidity, and the presence of wet conditions. So the goal of management is to restore the normal body temperature. So hold on. Sorry, I had my Roomba going, so I have to shut the door. So rewarming, and they may need an analgesic. So think about it. If we're rewarming, we're returning circulation, they may start having a lot of pain because they did not have sensitivity. Now they're going to have extreme sensitivity. So protection of the affected extremity or area once rewarmed, and risk for infection is the greatest concern. Now, because we had death of tissues because they weren't getting circulation. Now remember, cold constricts, it vasoconstricts, and they're not going to get circulation to that extremity. So when those tissues start to die and those cells break open, the potassium releases from the cell and gets into the bloodstream. So hyperkalemia. So emia means bloodstream. So we have too much potassium in the bloodstream. And then hypovolemia are also managed as well. So what we do is the constrictive clothing and jewelry that could impair circulation is all removed. If the lower extremities are involved, patients should not be allowed to ambulate because this can exacerbate tissue damage. Controlled yet rapid rewarming is instituted. Frozen extremities are usually placed in a 98.6 to 400 degree circulating bath for 30 to 40 minutes at a time. And because we want vasodilatation, but we don't want rebound vasoconstriction if they're in there too long. This is repeated until circulation is effectively restored. Early rewarming appears to decrease the amount of ultimate tissue loss. During rewarming, an analgesic is given because it's going to be painful. Now, massaging and handling of the body part is contraindicated because we don't want to blow a clot. Okay. Once rewarmed, the part is protected from further injury and elevated to help control swelling. Sterile gauze or cotton is placed between the affected fingers or toes to prevent maceration, and a bulky dressing is placed on the extremity. A foot cradle may be needed. Hemorrhagic blebs, which develop 1 hour to a few days after rewarming, are left intact and not ruptured. Non-hemorrhagic blisters are debrided to decrease the inflammatory mediators found in the blister. So this is all the management that's done for frostbite. Now, additional management, once the emergent, they're stable, they're going to do those whirlpool baths to the affected part, like I mentioned earlier. They might have to do an eschorotomy or a fasciotomy to release pressure, especially if we've got compartment syndrome. So how do you know they have compartment syndrome? They're going to lose their pulses, right? Their feeling, their movement. They may not have feeling and movement in the beginning of when they come into the ER. Hourly range of motion, because we don't want to lose that flexibility, and avoid vasoconstrictive agents. When we discharge them home, no smoking, no alcohol, and no caffeine, because that would hurt me because I love my coffee. But you get the point. It's going to cause vasoconstriction. Now, moving on to hypothermia. The core temperature is 95 degrees or less. So their body temperature is 95 or less. I mean, we're, 98.6 technically, give or take 1 point. or less because of exposure to cold or the inability to maintain the body temperature. Some medications or medical conditions decrease the ability to shiver. So patients with like spinal cord injuries, like we talked about in the SCI lecture, to shiver, inhibiting the body's innate ability to generate heat. So those people are at risk, spinal cord injuries. Alcohol drinking alcohol increases susceptibility of hypothermia because it causes systemic vasodilatation. That's why people pass out, and also because of dehydration. Some medications or medical conditions decrease the ability to shiver, like I mentioned, and the patient also may have frostbite as well, but we treat the hypothermia. And then the assessment, diagnostics, and management. And let me tell you, this is a funny cartoon, but this is true. He's not dead till he's warm and dead. Even in Florida, in the wintertime, it was like 40 degrees, which is probably our coldest days or nights down in the Tampa Bay area. We had the homeless people are very, very at risk. And there was a homeless man. The paramedics found him, picked him up, and he appeared dead. He didn't have a pulse, but his core temperature was very low. Now, I wasn't in the ER. I was in the neuro ICU, and they had to do CPR on him until he warmed up. So they were doing warming protocols, which I'll get to. And so the reason why I know this patient was in the ER, I was in charge in the neuro unit, and they called and they said, "Do you have anybody that's free, your tech, anybody that can come down and do CPR?" Because, of course, if you've ever done CPR, it's exhausting. We do those 2-minute rounds, right? And so they needed to continually do CPR until the patient's body was warm. They cannot pronounce the patient dead until their body is of normal body temperature. All right. So the physiological changes in all the organ systems in hypovolemia, there's neurological changes, there's pulmonary edema, acid-base abnormalities, and coagulopathy issues. Shivering may be suppressed as temps are less than 90 degrees Fahrenheit. Because shivering is our body's way to stay warm. Cardiac output and blood pressure are weak. Peripheral pulses may be undetectable. So we want to do CPR. They can get cardiac arrhythmias. We're going to monitor. We're going to do circulation, airway breathing. Rewarming, or internal core temperature. Active, that's going to be the active warming. We've got passive rewarming and active external warming. And then we're going to do supportive care. So let's look at the notes here. Lots of notes. Hypothermia leads to physiologic changes in all organ systems. Patients, when they start getting cold, they're apathetic, they have poor judgment, they have ataxia, dysarthria, they can't talk, they're drowsy, and that's what happens. They get sleepy and they fall asleep in the cold. They can get pulmonary edema, acid base, and like we said, in coma. Management of hypothermia you have to remove those wet clothes, continuous monitoring, rewarming, and supportive care. So we talked about vital signs, central venous pressure, urine output, ABGs, bone creatinine, chest x-rays, because we're looking for the kidneys, the lungs, things like that. Core body temperatures monitored, again, with the esophageal, bladder, or rectal thermistor. Continuous ECG. Cold induces myocardial irritability and leads to conduction disturbances like VFib. They're going to put in an A line for rapid, immediate blood pressure and blood sampling, because you can get your ABGs. Active internal rewarming methods are used for moderate to severe hypothermia, so 82.5 to 90 degrees Fahrenheit, and include cardiopulmonary bypass, warm fluids. So they're going to get the fluids are kept in like a warming closet or cabinet, warmed humidified oxygen by the ventilator, and warmed peritoneal lavage. So they can put an NG tube in and give warm fluids, warm water. Monitor for VFib as the patient's temp increases to 88 to 90. Passive and active external rewarming is used for mild hypothermia from 90 to 95. Over-the-bed heaters, like those bear huggers to extremities. So they're going to put those over the heaters over the extremities because it increases the blood flow. But over-the-bed heaters to extremities, it increases blood flow to the acidic anaerobic extremities. The blood flow from peripheral tissues has high lactic acid levels. So think about this. We're going to have that venous return, right? As the blood returns to the core, It causes a significant drop in the core temperature again and can potentially cause cardiac arrest and electrolyte disturbances. So active external rewarming uses forced warming air blankets. So the extremities are nice and warm, and we got warm blood going to the core instead of cold blood going to the core. Okay, so then we've got supportive care during rewarming includes the following. So we've got external cardiac compression, typically performed only as directed in patients with temperatures higher than 31 degrees, 88 degrees Fahrenheit. Defibrillator and ventricular fibrillator, we keep that code card at the bedside. Patient whose temperatures are less than 90 degrees Fahrenheit experiences spontaneous ventricular fibrillation if moved or touched. Defibrillation is ineffective in patients with temperatures lower than 31. Therefore, a patient must be rewarmed first. And we just continue to do CPR. That's what I said. I think they did CPR on that guy for like 2 hours. And I had to go to the medical ICU to get a bladder scanner. Everyone's stealing the bladder scanner. Anyways, and there he was like 2 days later, sitting up, eating a regular diet, getting ready to be discharged. Shaved and cleaned and deloused and everything, ready to go back outside. So hopefully they got some case management so he could get some help. But mechanical ventilation with PEEP and heated humidified oxygen, administration of warmed IV fluids, like we said, to correct hypotension, maintain urine output, core rewarming, administration of sodium bicarb to treat the metabolic acidosis, and antiarrhythmic medications as needed, and put in a Foley to watch that urine output and watch for kidney function. All right. So let's move on to non-fatal drowning. We used to call it near drowning, but survival for at least 24 hours after submersion that cause a respiratory arrest. So we don't want to give up on these patients that we find that have been under the water. Try to work on them. And they could be hypoxic. I mean, you swim in 80-degree water, 70-degree water for a long period of time, you're going to get hypothermic. That's why divers wear wetsuits, so they can stay warm. High-risk ages, again, are going to be the children, the elderly over 85, and children under 5. This is preventable because avoid swimming in rip currents, and I think that's a rip current right there. We can see the waves aren't coming together, and that's how surfers know, and that's how I was taught when I lived in California and I would surf, and I would wear a really thick wetsuit because it's really cold in San Francisco. And so you wouldn't get sucked in. Let me tell you, that Pacific Ocean is very powerful. And pool drownings are preventable with the fence, swimming lessons, things like that. Boating, make sure people have flotation devices and things like that. Factors associated with drowning and non-fatal drowning are alcohol, inability to swim, diving injuries, and hit-related injuries. So because people dive, they break their neck, and then they're also a near drowning. So a lot of my patients who broke their neck in Florida because they dove, also I had to do non-fatal drowning care. Submersion in cold water promotes successful resuscitation because it decreases metabolic demands, and they lose their dive reflex, and they just, that way we also have to treat the hypothermia. Non-fatal training process involves onset of hypoxia because if they're drowning, they're not getting oxygen to their organs and their brain. They usually die of hypoxic brain injury. Well, of course, yeah. And then hypercapnia, too much CO2, bradycardia, and arrhythmias. Freshwater versus saltwater. So the big thing, there's a difference between freshwater and saltwater. So freshwater aspiration results in loss of surfactant and thereby inability to expand the lungs. Where saltwater, think about it, water follows salt, right? So they get pulmonary edema from the osmotic effects of the salt pulling the water into the lungs. If a person survives immersion, they have the ARDS resulting from hypoxia, things like that, respiratory or metabolic acidosis. Another thing, if